Hello, my name is Melissa Franco. I come from University of Miami, and I'm going to talk to you about one of the common questions that I get in hepatology, which is the use of ammonia levels in patients with cirrhosis. And I want to start by reviewing what hepatic encephalopathy is. So hepatic encephalopathy is a brain dysfunction caused by liver insufficiency that could manifest as a wide spectrum of neurological and psychiatric abnormalities ranging from mild symptoms to coma. Hepatic encephalopathy should be classified according to the type of underlying liver disease, severity of manifestations, time course, and precipitating factors. Hepatic encephalopathy is classified into three types, type A, B, and C. We're going to focus on C, which comes from cirrhosis. And there are also different grades of hepatic encephalopathy that go from covert to overt. Minimal and grade 1 stand for covert, and grade 2 through grade 4 stand for overt encephalopathy. So minimal encephalopathy, we don't see any clinical evidence of mental changes. In grade 1 or covert, we see symptoms such as euphoria, lack of awareness, anxiety, shortened attention span, and changes in the sleep rhythm. In grade 2 or overt, you will find lethargy, apathy, disorientation, inappropriate behavior, and asterixes. Grade 3 or overt, you will see somnolence, confusion, and bizarre behavior. Grade 4, we see coma. What is the time course of this encephalopathy? Is this episodic? Is this recurrent? Is this persistent? And we have to note for the precipitants. Possible precipitants that we commonly see are gastrointestinal bleeding, medications such as benzodiazepines, narcotics, infections, diuretic overuse, and the diagnosis. Now, about the diagnosis, this is a clinical diagnosis. We don't diagnose hepatic encephalopathy by ordering ammonia levels. Of course, we have to take a thorough history and physical examination, which is notorious for asterixis, but is not pathognomonic. There are some tests that we use, such as Stroop test and the Rayton test, that could aid in the diagnosis of hepatic encephalopathy. Despite its poor prognostic accuracy, ammonia levels are ordered by clinicians in patients suspected for hepatic encephalopathy because clinicians feel more comfortable by ordering this test. However, the diagnosis remains a clinical diagnosis. High blood ammonia do not add to any diagnostic, staging, or prognostic value in hepatic encephalopathy patients. Ammonia shouldn't be used to diagnose or exclude hepatic encephalopathy. Ammonia blood levels do not reliably detect hepatic encephalopathy. Some studies found no relationships between ammonia levels and hepatic encephalopathy grade or symptoms. You may have a stable patient that has an elevated ammonia level that is not encephalopathic, and you could also have a patient with encephalopathy with normal ammonia levels. So normal ammonia levels should not be used to rule out hepatic encephalopathy when there is a clinical suspicion. The treatment for encephalopathy are lactulose and Xifaxan. Lactulose is a non-absorbable disaccharide that prevents absorption of ammonia, and the dose is 30 milliliters 3 times a day to achieve at least 3 bowel movements per day, and Xifaxan 550 milligrams twice a day.